Hi everyone, and welcome to our module on Protozoa. So when you hear people say that someone has a parasite infection, they usually mean that they have a protozoal infection. Sometimes they're also talking about a helminth or worm infection, but when we say someone has a parasite, we're usually not talking about fungi or bacteria. So let's talk about what a protozoa is. A protozoa is a eukaryote, so this is a more modern form of life than bacteria. Protozoa have a nucleus, they have intracellular organelles. They're very different from prokaryotes, which are what bacteria are. Protozoa are unicellular organisms. They are mobile and they're usually easy to see under the microscope. You can often see them swimming around on the slide. Protozoa have complex life cycles, and you don't need to know the entire life cycle of all the protozoas that cause human infections. But you do need to know that protozoa exist in different stages, and the two most important stages are the trophozoite stage and the cyst stage. So trophozoites are the feeding form of protozoa, and this is usually the form that develops inside the body. This form is vulnerable to environmental conditions and you're usually not going to find it out in nature. The cyst form is the more durable form, and this is what's often found in nature. In fact, it's often found in feces of animals, and then it can get into the water, and then you can get infected with the cyst, which can then turn into the trophozoite form and cause disease. From a medical or symptom point of view, you can break down the protozoa infections into several categories based on the type of illness they cause. First are the GI illness protozoa, and these are protozoa like Giardia and Entamoeba and Cryptosporidium, and they all cause various forms of diarrhea. Next group are the protozoa that infect the central nervous system. The most important one is Toxoplasma, but we'll also talk about Naegleria and also the bugs that cause sleeping sickness. There are two protozoa that infect the blood. The first is malaria, which is very important, and we have a separate module on malaria. The other one is Babesia, which we'll talk about in this module. And then finally, there are a couple that are just in a unique group by themselves, like Chagas disease, leishmaniasis, and trichomonas, which is a sexually transmitted disease. There are a couple of rules of thumb that can help you a lot in board exams to answer questions about protozoa. And the first one is that all GI protozoa have transmission that is fecal to oral. So infected humans or infected animals pass cysts in the stool, which get into the water, and then consumption of contaminated water is the way that people get sick. We'll talk about this in more detail when we talk about each individual protozoa. The other protozoa have various methods of transmission. So trichomonas is a sexually transmitted disease. You get toxoplasmosis by contact with cat feces, and then mosquitoes and flies are how you can get malaria and babesia. Another thing to know is that metronidazole is an antibiotic that works for several protozoal infections. Even though it's antibacteria, it works against the GI parasites Giardia and Entamoeba, and it's also effective against the sexually transmitted disease trichomonas. Most of the other drugs used to treat protozoa are unique to each one, and they all have very strange names, and you won't see them used in many places outside of protozoal infections. This can actually be helpful to you because if you see a board question and you recognize that it's a protozoal infection, then any of the answer choices that list antibiotics are not going to be correct. So for example, for Entamoeba, there is a drug called iodoquinol that can be used. For Cryptosporidium, you can use nitazoxanide. Trypanosomes can be treated with a drug called Suramin. There's also a drug called Molarcipol for trypanosomes. Atovaquone is a malaria drug, but it also works for Babesia, and that can help remind you that Babesia and malaria are the two blood parasites because they have a drug that works for both of them. Nifurtimox is used to treat Chagas disease, and finally there's a drug called sodium stibogluconate, which can be used for leishmania. And I mention these names only so that you've heard them once, and the most important thing is to recognize that these are unique drugs used for protozoal infections. That will often help you determine whether it may be correct or incorrect for a board question. So first let's talk about Giardia lamblia, which is the cause of giardiasis. So Giardia cysts are found in moist environments, and the classic source is water from a mountain stream. So the Giardia cysts like the wet mud and they get into the water, and then if you're hiking and you drink some stream water, you can get infected. When you ingest the cysts, they turn into the trophozoite form in the intestines, and these bugs affect the small intestine. And what they cause is not bleeding or inflammation, but they cause malabsorption of fat in the small intestine. Therefore, you will get bloating and foul-smelling fatty diarrhea. This is called steatorrhea, and steatorrhea classically gives you stools that float. It's very unusual for your stools to float. You may not like to think about that, but usually you probably notice that they sink to the bottom of the bowl. Not if you have a Giardia infection and not if you have steatorrhea. The way you diagnose Giardia is by finding cysts in the stool or trophozoites in the stool. You can also do an ELISA test for Giardia antigens. This is a picture of a Giardia cyst down here on the left, and you can see it looks like a tiny egg. And these are the trophozoites over here on the right, and they have multiple flagella that they use to move around on the slide. So the classic case of Giardia infection is a camper or hiker who develops diarrhea and flatulence and symptoms that fit with steatorrhea. That person has a Giardia infection of the small bowel, and the treatment for this is metronidazole. There's an important tie-in with immunology when it comes to Giardia, and that has to do with the antibody IgA. Recall that IgA is very important for defense of the mucosa, and that includes the GI mucosa where Giardia infection occurs. IgA, it turns out, is especially important for defense against Giardia. There have been a number of studies showing that lack of IgA antibodies can lead to severe and recurrent infections. I've listed one of them on the screen here if you want to read more. So if you lack IgA for any reason, you can suffer recurrent and chronic Giardia infection. So a couple of immune deficiency syndromes are associated with IgA deficiency. This includes Bruton's and selective IgA deficiency, and these patients can potentially get a severe Giardia infection. And just remember that Giardia ends in the letter A, and that will remind you that IgA is very important for this protozoa. Next protozoal infection is caused by Entamoeba histolytica, and this is the causative agent of amoebiasis, or it's also called amoebic dysentery. This protozoa is found worldwide, but it's very common in developing countries where people live in conditions with poor sanitation. Just like with Giardia, you get this infection by ingesting cysts in contaminated water. And also, just like Giardia, the cysts form trophozoite forms in the small intestine. But what's different from Giardia is that in this case, Entamoeba likes to invade the tissue of the small bowel. This is going to cause bloody diarrhea, which is also known as dysentery, and that's where it gets its name, amoebic dysentery. After it invades the small bowel, it can invade the portal system and ascend and go up to the liver. So amoebiasis often gives liver symptoms. In particular, people get abscesses in the liver, so they will complain of right upper quadrant pain, and a classic finding at surgery is to see anchovy paste exudate. So these abscesses will be full of necrotic tissue that's got this red-yellow color to it, and it's classically described as looking like anchovy paste. I've never used anchovy paste for cooking, but if you do, this is what it looks like. So the classic case for someone who's got amoebiasis is going to be a traveler to a foreign country who comes home and has bloody diarrhea and right upper quadrant pain. That person has an Entamoeba infection. Just like with Giardia, you can diagnose Entamoeba infections by stool microscopy, but the findings are a little bit different. So down here on the right is a cyst from an Entamoeba infection, and it's a circular cyst just like Giardia, but what's different is that these cysts have multiple nuclei. You can see at least 2 or 3 or maybe 4 different circular nuclei inside the cysts, and that's what you see in Entamoeba infections. There's also a trophozoite form that you can see with Entamoeba infections, and the classic trophozoite form has ingested red blood cells. So this trophozoite right here has ingested multiple red blood cells. Those are those dark circles inside, and that's what you see with Entamoeba infections. There are also antibody tests you can do for Entamoeba infections. These tests are not good in countries where this infection is endemic because lots of people have been exposed. But if someone travels briefly to Africa and comes back with an infection, the antibody test can be very useful because if they're positive, then they likely have an Entamoeba infection. The treatment for the active infectious form is metronidazole, but metronidazole won't get rid of the cysts. So what you have to do is give a second agent called iodoquinol. This is called a luminal agent because it stays in the GI lumen and it will eliminate the cysts. So this can be given to people after they've cleared their infection. You can also give it to people who are asymptomatic cyst carriers. It will get rid of those cysts in the GI lumen. There's a classic histopathological finding in patients with amoebic dysentery, and it's called a flask-shaped ulcer. This is an example of it right here. You can see that the infection has broken through the mucosa here, and then it's expanding deep within the tissue, and it forms this shape that looks somewhat like a flask. So the classic case of Entamoeba infection to know for your boards is a patient who is in a developing country, or someone who recently emigrated or came back from a trip to a developing country, now has bloody diarrhea that develops over several weeks and has right upper quadrant pain from the liver involvement. And then the final GI protozoal infection is caused by Cryptosporidium, which causes cryptosporidiosis. This is a protozoal infection that you get from the ingestion of eggs, which are called oocysts. These are found in contaminated water, just like all the protozoal GI infections. And when you ingest the oocysts, you get an infection. One thing that's important to know is that chlorination does not destroy these oocysts, so infection has been reported in people who drink water from swimming pools. A lot of times little children will drink some of the swimming pool water, and even though it's chlorinated, they can still get this infection here. The biggest problem is in people with HIV/AIDS. If you're immunocompetent, this will cause a mild watery diarrhea. It's self-limited. It usually occurs in a child, and it's often presumed to be viral. You would never even send diagnostic tests to work this up in most cases. However, people who have HIV or AIDS can get a very severe diarrhea from Cryptosporidium infection. You diagnose this by microscopy just like all the GI protozoal infections, and the thing to know here is that these oocysts are acid-fast. So the acid-fast stain everyone knows is used for tuberculosis. What people don't often think of it for is Cryptosporidium infections, and also it can be used for nocardia infections. So Cryptosporidium oocysts are acid-fast, and they will turn purple when you stain them with the acid-fast stain, just like the Mycobacterium of tuberculosis do. There is a treatment for immunocompetent patients that's called nitazoxanide. If you have HIV/AIDS, really the only thing you can do to treat this is use antiretroviral therapy to try and raise the CD4 count. Nitazoxanide has been disappointing in clinical trials for efficacy in people with HIV/AIDS. And really prevention is the key here. People need to wash their hands and use filtered water so that they don't drink contaminated water and get the oocysts. So let me pause here and review the 3 GI protozoal infections. So they all come from drinking contaminated water. If it's a hiker or camper who has steatorrhea, so that includes foul-smelling greasy stools, that person has Giardia. They will also have cysts in the stool and trophozoites with the flagella, and Giardia infections are treated with metronidazole. If it's someone who's been to or lives in a developing country who has bloody diarrhea and right upper quadrant pain, also with cysts and trophozoites with those ingested red blood cells, that person has amoebiasis. And both Giardia and amoebiasis can be treated with metronidazole. Finally, if it's someone with watery diarrhea, especially someone with HIV and AIDS and the acid-fast oocyst, then that's a person who has Cryptosporidium. The next infection we'll discuss is infection with the protozoa Toxoplasma gondii. This leads to toxoplasmosis. This is one of the central nervous system protozoal infections. Toxoplasma is commonly found in cats or felines, although it can also be found in other animals. And the animals that are infected will shed a form of the protozoa called an oocyst in the stool. And you can become infected if you accidentally consume those oocysts. For example, they're often found in the soil. There's also a second way you can get infected. That's if you eat meat from a contaminated animal. So a form of the protozoa called a cyst is found in contaminated animals, especially pigs. And if you eat contaminated meat, then you can get a toxoplasma infection. By whatever mechanism you consume the protozoa, once it gets into your intestine, it invades and then disseminates in the body. And one thing that's important to appreciate about toxoplasma is that the initial infection is often asymptomatic, but the protozoa can enter a latent phase in the body and reactivate later, and as we will see, this is especially a problem when people become immunocompromised. There are 2 major disease processes caused by toxoplasma. The first one is HIV CNS disease, and the second one is congenital toxoplasmosis. Toxoplasma causes significant central nervous system disease, but only if you are immunosuppressed. Now, usually this is an HIV or AIDS patient. You need to have a very low CD4 count to get toxoplasmosis, usually less than 100. It can also be someone who's on high-dose immunosuppressants, for example, people who've had a solid organ transplantation. And you should know that sometimes toxoplasma reactivates. So a lot of people are exposed, and sometimes they have latent infection in their body, and once you place them on the high-dose immunosuppressants, they can develop toxoplasmosis. And patients going for solid organ transplantation are often screened for exposure to toxoplasma because if they've been exposed, latent and reactivation infection is possible. The symptoms of CNS disease are brain abscesses, so it can be fever and headache and nerve palsies depending on where the abscess is. And the classic imaging finding are multiple ring-enhancing lesions. So because it spreads through the bloodstream, there will be multiple lesions, not just one, and they are ring enhancing, and this is a picture of a ring enhancing lesion on an MRI of the brain. Toxoplasma can cross the placenta, and remember that pregnant women are not supposed to change the cat litter, and that's to avoid exposure to this protozoa. If the baby gets infected in utero, there is a range of symptoms and signs that can be seen, but the classic triad of a fetal or newborn toxoplasma infection is chorioretinitis, so this is inflammation of the choroid, which is the vascular layer of the eye, hydrocephalus, and finally calcifications inside the brain and the skull. This is often seen on imaging. So of the 3, the one I have always remembered and the one that almost always lets me get this right in board questions is the intracranial calcifications. You know that toxoplasma causes CNS disease in HIV/AIDS, so it makes sense that it infects the CNS of babies. And you can sometimes see these calcifications on a fetal ultrasound. So a fetal ultrasound of a mother who has toxoplasma may show calcifications in the brain or around the ventricles of the baby, and that is a sign of toxoplasma being passed on to the fetus. You can also sometimes see enlarged ventricles in utero with ultrasound, which is evidence of hydrocephalus. You can diagnose toxoplasma by serology tests. There are IgG and IgM antibodies that you can detect in the lab. The IgM antibodies, as usual, are temporary, so they appear in a week and rise and decline. If the IgM antibodies are elevated, it suggests a recent exposure. IgG antibodies will rise within 2 weeks and then generally persist for life, so elevated levels of IgG antibodies do not necessarily suggest a recent infection. You can also identify the protozoa on a biopsy, so what they like you to be able to identify for step 1 is the tachyozoite stage. It's usually visualized with a Giemsa stain. Remember, Giemsa stain is used for malaria, and so it's used for protozoas, and it's good for toxoplasma too. And you will see these little curved purple worm-like things growing inside the body, kind of nasty looking. And that's the tachyozoite of toxoplasma. The most effective regimen for toxoplasma and the treatment of choice is the combination of sulfadiazine and pyrimethamine. These two drugs together sequentially block the THF synthesis pathway the same way that TMP-SMX does when it's used as the antibacterial Bactrim. Sulfadiazine is a sulfonamide, and pyrimethamine blocks the same enzyme as trimethoprim. This combination is used uniquely for toxoplasma because it's been shown to be the most effective therapy. The next protozoal infection is Naegleria fowleri. This is a very rare cause of fatal meningoencephalitis. Only about 300 cases have been reported worldwide. This protozoa is found in freshwater lakes and ponds, and when you swim in contaminated water, it can get up your nose and enter the cribriform plate and go directly into the brain. The classic case is someone who recently went swimming a few days ago, now has fever, confusion, and a stiff neck. It'll look like meningitis, and it's often fatal, about 99% in one series. Unfortunately, if you Google this online, you'll find websites of children who died from this after swimming. It's very rare, but this is the kind of thing that'll scare you from going swimming in any natural stream or pond. And what they like you to know for step 1 about this is the cribriform plate. So this disease is used to provide relevance to the anatomy of the skull, and they will ask you how the protozoa got into the brain, and you need to know that it went straight into the nose and through the cribriform plate into the brain. African trypanosomiasis is a protozoal infection caused by several protozoa that all start their name with the word trypanosoma. There's Trypanosoma brucei and gambiense and rhodesiense, and all of these cause trypanosomiasis. These are infections that occur obviously in Africa, that's where the name comes from, and they're all caused by an insect bite. Specifically, you get all these infections if you get bit by the tsetse fly. And these infections are called the African sleeping sickness because many patients fall asleep and slip into a coma. Early after infection, you can get symptoms like fever and arthralgias, but later people become very somnolent and sleepy, and they can go into a coma, hence the name. And you can diagnose this by visualizing the organisms on blood smear. This is a picture of a trypanosome in a blood smear. I classify this as a central nervous system because people go into a coma, but the organism also infects the blood, so you could also call it a blood infection as well. You may be wondering why the United States medical licensing exam wants you to know about an infection that only occurs in Africa, and the reason is because there's a very important tie-in with immunology. A key feature of African sleeping sickness is recurring fever, and this is due to antigenic variation. There are glycoproteins on the surface of these trypanosomes called variant surface glycoproteins, or VSGs, and each trypanosome is covered with about 10 million copies of one single VSG. And the trypanosome will change the VSG whenever the host mounts an immune response. This will result in waves of parasitemia. The immune system will control the infection, then the VSG will change, and then the parasite will grow, and this results in recurring fever. And this antigenic variation in recurring fever is the high-yield feature of trypanosomiasis to know about for your boards. The next protozoal infection is Babesia, which is what causes babesiosis, and this is transmitted by the tick Ixodes scapularis. And this is the same tick that bites people to give you Lyme disease caused by the bacteria Borrelia. It's also the same tick that carries the bacteria Anaplasma, which can cause anaplasmosis. So co-infection is common. When someone presents with Babesia, you need to check them for Lyme and vice versa. And a common board question is to describe a classic Lyme patient and ask you what other infection do you need to worry about, and the answer is Babesia. Babesia has the same geography as Lyme. It happens in the northeast United States, so places like Connecticut and Massachusetts and New York. It infects red blood cells, and this is similar to Plasmodium, which infects red blood cells and causes malaria. And one thing to know is that patients who are asplenic, so if they've had their spleen removed, are at increased risk for Babesia because the spleen clears the red blood cells that are infected, and it obviously can't do that if you don't have a spleen. If you know that Babesia infects red blood cells, then the symptoms are pretty easy to make sense of. You get fever, which is a sign of infection. You get hemolytic anemia from the protozoa lysing the red cells that it infects. And you get splenomegaly as the spleen tries to clear those infected red blood cells. The diagnosis can be made by a blood smear. What you see on a blood smear are ring forms of the protozoa. Now you also see ring forms in patients with malaria, but the patient demographics are going to be completely different. Malaria is going to be someone who's been to Africa. Babesia is going to be someone who's been hiking in the woods in the northeastern United States. The ring forms are sometimes described as Maltese crosses. So this is a Maltese cross up here in the top right corner. The Maltese cross was a symbol of knights in the Middle Ages from the island of Malta, which is in the Mediterranean near Italy. And this shape is seen in a couple of pathological conditions. When you get multiple ring forms inside a red blood cell, it can sometimes look like a Maltese cross. In patients with the nephrotic syndrome, the fatty casts in the urine are also described as having the shape of a Maltese cross. And if you look at these pictures down here, what you see are red blood cells infected with Babesia protozoa, and there are lots of these little ring forms inside the cells, and sometimes you can get a couple of them together that look sort of like a Maltese cross. You can also diagnose Babesia by PCR, where you can amplify the Babesia RNA. There are two treatments used for Babesia. The first is azithromycin, which is a macrolide antibiotic, and the second is atovaquone, which you may know is a malaria drug, and it's another way to remind yourself that Babesia and malaria share a lot of similarities, especially when it comes to infecting the red blood cells. Trypanosoma cruzi has the name trypanosoma in it, but it does not cause African sleeping sickness. Trypanosoma cruzi causes Chagas disease, and you get this disease usually in South America by getting bitten by the reduvid bug, and this is a picture of the reduvid bug down here. These bugs nest in the cracks and holes of housing, so this is going to happen to people who have been exposed to poor and unsanitary conditions in South America. There's an acute illness after you get bitten and get infected by the protozoa. It's a non-specific illness with a fever, but chronic Chagas disease is what is the biggest problem. This affects the heart, the esophagus, and the colon. In the heart, chronic Chagas disease causes right and left heart failure. There will be signs and symptoms of severely depressed right and left ventricular function. There's also a high prevalence of ventricular thrombi. The blood flow can get so sluggish that clots form in the heart, and these clots can break off and cause a pulmonary embolism or a stroke. In the esophagus and the colon, what you get is essentially loss of motility. So in the esophagus, you can get achalasia, and you can get a dilated frozen esophagus called megaesophagus. In the colon, you can get megacolon, which is a dilated immobile colon, and this gives severe constipation. So people with a Trypanosoma cruzi infection chronically are going to complain of difficulty swallowing and constipation, and they're also going to have signs of heart failure. You can diagnose the acute phase of Chagas disease by doing a blood smear. There is a form of the protozoa called a trypomastogote that you can see in a blood smear. This is a picture of one right here swimming around with the red blood cells. Kind of creepy to think about that in your bloodstream. In the chronic phase, you can do serological testing and find IgG antibodies to Trypanosoma cruzi. There is a treatment for the acute phase. It's a unique drug called nifurtimox. It's only used in the acute phase. It's not effective in advanced disease. Mostly in advanced disease, what you have to do is support the failing heart and treat the problems in the esophagus and the colon with supportive care. There's really not any type of antibiotic to reverse those problems. Leishmania donovani causes leishmaniasis, and this is a protozoal infection that's transmitted by the sandfly. It's mostly seen in Asia. You can see it in India. You can see it in Africa and South and Central America. In this infection, the protozoa gets into the body and infects macrophages. I'll show you some pictures of that in a minute. What most people think of when they hear the word leishmaniasis is the cutaneous form. This is a picture of it down here. So people from the countries where this is endemic will have these ulcers all over their body on the skin. These are large ulcers with indurated borders, and that's the cutaneous form of leishmaniasis. There is also a much more deadly and dangerous visceral form where the protozoa gets into the body. It's sometimes called Kala Azar, which is a Hindi word for black fever, because some patients with this condition will get a discoloration of the skin. People with the visceral form get fever, they get very big, painful spleens, and they can have pancytopenia from involvement of the bone marrow. The skin form can be diagnosed just by recognizing the typical lesion, but the visceral form is usually diagnosed by a biopsy of an organ that's affected, and this is usually going to be the bone marrow or the spleen, because remember, these people have very large spleens and they have pancytopenia, so the bone marrow is involved. And what you will see is the protozoa form called an amastogote inside of macrophages. So this is a picture of one down here, and this is a macrophage with little tiny purple inclusions, and those are the Leishmania protozoa. This infection can be treated with amphotericin B. Now that's an antifungal drug, but it works in Leishmania because there is some ergosterol in these protozoal cells. In addition, it's thought that the amphotericin disrupts the cholesterol in the macrophages, and this helps to destroy the place where the protozoa is living. There's also a unique drug used for Leishmania called sodium stibogluconate. The last protozoal infection we'll talk about is called Trichomonas vaginalis, and of all the infections in this module, this is the one you're most likely to see in actual clinical practice. Trichomonas lives in the urogenital tract and it is sexually transmitted. There's no cyst form that you can be exposed to in nature to get an infection with Trichomonas. In men, an infection is usually asymptomatic, although it can cause urethritis with symptoms like discharge and dysuria. About half of women are asymptomatic, but the other half have symptoms of vaginitis, so they will have itching, and they classically have a yellow-green, foul-smelling discharge, and I'm circling the word foul-smelling because that is a buzzword for Trichomonas infection in board question stems. You can diagnose Trichomonas by doing what's called a wet mount. This is where you take a sample from the vagina and look under the microscope for evidence of motile trichomonads, and these are pictures of motile trichomonads here in the top right screen. You will also find in Trichomonas infection that the vaginal pH is elevated. A normal vaginal pH is about 4 to 4.5, and it will be greater than 4.5 in women who have a Trichomonas infection. The treatment for Trichomonas is metronidazole, and you need to treat the patient and the partner because the partner is usually infected as well. And you should know that Trichomonas is one of the three main causes of vaginitis. So when women present with discharge and itching from the vagina, there are three potential infections that can cause this problem. The first one is Trichomonas, which we've been discussing. The second one is Candida, which is a fungi. And the third one is bacterial vaginosis, which is caused by a bacteria called Gardnerella vaginalis. And the classic finding that you should know about for a Gardnerella vaginalis infection is a clue cell. So this is a picture of a clue cell. This is a vaginal epithelial cell, and it is studded with bacteria, and that's a clue cell, and that is diagnostic of bacterial vaginosis. This is a pretty classic table that you can find in many textbooks and online, and it explains how to tell the difference between the three infectious causes of vaginitis: bacterial vaginosis, candidiasis, and Trichomonas. So let's go through it now. So first let's talk about bacterial vaginosis. So the thing to remember about bacterial vaginosis is that it has a fishy odor. It has a fishy odor just when it's present in the vagina, and then additionally there's something called the whiff test. When you add potassium hydroxide to a sample from the vagina, it will smell very fishy, and that's called a positive whiff test. And that's seen in bacterial vaginosis. Bacterial vaginosis is not an STD, but it's more common in women who've had lots of sexual intercourse. That makes the infection more likely to occur. The discharge in bacterial vaginosis is thin and off-white. It's sometimes called gray. It's treated with metronidazole, and it has an elevated pH. All these infections have an elevated pH except for Candida. So next let's talk about Candida. Candida has a thick white cottage cheese discharge. And you know that Candida can cause thrush in the mouth, which makes a thick white plaque. So it's easy to remember that can cause the same thing when it causes vaginitis. Sometimes when you examine the tissue in women with vaginitis, it's a little bit red or erythematous. The way you identify Candida is by doing a KOH prep and looking under the microscope for presence of pseudohyphae. And you can treat candidiasis with fluconazole, either topically or with an oral form. And then finally, Trichomonas is what we've been discussing. It's got a yellow-green discharge that's described as foul-smelling. One unique physical exam finding is when you examine the cervix in women who have a Trichomonas infection, it will be bright red, described as a strawberry cervix. The pH is elevated here. The special diagnostic test to find Trichomonas is the wet mount, like we looked at on the last picture, to see those motile trichomonads. And then finally, you treat Trichomonas with metronidazole. And that concludes our module on Protozoa.